Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's episode is part 2 of our discussion with Dr. Chris Kabrhel as part of our eQual VTE initiative. Chris is an internationally recognized VTE researcher. He's from Mass General Hospital in Boston, and we're excited to have him back today to dig in a little bit deeper from where we were on the last episode. Welcome back, Chris.
Great to be here.
So when we left off last time, we had just started talking about PERT teams. And I want to talk about these PERT teams a little bit more, especially with you, because you're essentially there from the start. We had Jeff Klein on a prior podcast, and he said you might be the father of emergency medicine PERT teams. And so give us the Reader's Digest version on the history of those, what they are, and sort of what's going on with these PERT teams around the country.
Yeah, happy to. PERT teams started in Mass General Hospital. There was a case that didn't go quite the way everyone would have liked it to have gone. And I think that's probably a story that we have heard in emergency medicine and quality research for almost every innovation that's come down the pike. We did not like the way a particular case went, and a group of us who were interested in PE got together in the emergency department training room. It was me, Ken Rosenfield, who's an interventional cardiologist, Rich Chanik, who's a pulmonary critical care physician and pulmonary hypertension expert, and Tor Sunt, who's the chief of cardiovascular surgery at MGH. And we sat around and talked about the case and what we might do better. And in that room that day, the concept for a rapid response team that would be available to any clinician in the hospital who had diagnosed a PE and was worried about the clinical status of that patient, that would be a team that was available to them to provide access to interventions, advice on further diagnostic testing and workup, and the ability to facilitate moving a patient from the emergency department to the cath lab or to the OR as needed. We incorporated the use of ECMO into the team from the very beginning. We had catheter capabilities and we had surgical capabilities, but I was the emergency physician there, and I designed a lot of the pathway that is now used for PERT teams. So the way a PERT team typically works is you will activate a team in the same way you might activate your stroke team, your trauma team, your STEMI team. The difference between those teams and a PERT team is that whereas a stroke team is typically a neurologist and maybe a radiologist, PE is really a multidisciplinary disease, and it is cared for by emergency physicians who make the vast majority of the diagnoses and do the risk stratification and initiate treatment, but also by cardiologists, interventional radiologists, pulmonologists, surgeons, intensivists, hematologists. And so what we found relatively early on was two big things. One, there were a lot of new technologies and treatments that were coming available that had never been compared in large clinical trials. And so while we believed that there was a lot of potential for these interventions, we had no way of writing an algorithm that would tell people what to do. The other thing that we found was that the different specialties often had different opinions. So one of the early reviews I once wrote borrowed from the Abraham Lincoln biography, The Team of Rivals. And that's really what PERT teams are. It's a team of people who often have very different perspectives on what the right treatment for a PE should be, and yet get together in real time, usually by a video conference, to discuss a patient and come up with the best course of action based on the patient, their comorbidities, and the data that are available from diagnostic tests. Once that decision's made, because we have these various specialties on the call, we can activate and mobilize the resources that are needed rapidly and avoid the problem that we often have in emergency medicine, which is that we have to call 6 people to get one thing done. And so by putting it all into this pipeline, we're able to share diverse opinions, come up with what I think is the best treatment plan for the patient, and then mobilize the resources that the patient needs.
So tell us, this sounds like a monumental task to bring that team of rivals together. Tell us a little bit about some of the challenges that you faced early on, kind of current challenges now.
Yeah, there were a lot of challenges. We were lucky in that everyone at our shop was very invested in the idea. No one really was worried about being paid for their time on the PERT team. No one was really worried about reimbursement, although I understand that that's often a question at other places. There were certain resources at MGH, like a team of vascular medicine fellows that were taking call for STEMI anyway. And so we were able to leverage existing resources to take call for PERT. And I will give credit to the decades now of fellows who have taken these calls and done an amazing job. And we never really ran into the trouble that a lot of places had figuring out how to talk to each other and debate what the right treatment was. One of the challenges that I've heard from other hospitals is that they think that the PERT team is there to provide an algorithm that they can follow and say, this is the best treatment. And that isn't really what we're all about. In fact, if we knew what the best treatment was for any given patient, we probably wouldn't need a PERT team, right? The reason that we exist is because there's never been a study that directly compares catheter-directed thrombolysis to systemic intravenous thrombolysis. Until recently, there haven't been any large randomized controlled trials looking at catheter-directed thrombolysis versus heparin alone or anticoagulation alone. Those studies are still ongoing, so we don't even have the data today. There are newer technologies like suction thrombectomy catheters that, again, haven't been compared against anticoagulation alone in randomized trials or against catheter-directed thrombolysis. So the point of the PERT team isn't to provide an algorithm that everybody can follow. It's to provide expert consensus in real time in an absence of those algorithms and in an absence of the good randomized controlled trial data that we hope someday we'll have, but currently do not.
That's a really important distinction. And I really like that point, is that we know we have this massive problem in knowledge translation in medicine, right? Like I think 20 years ago, Beth McGlynn's group did this thing that said research comes out and basically it takes 17 years for a RCT level data to get its way into a guideline and the guideline to get its way into practice. And what this feels like is this is one of those intermediate solutions. We don't have that RCT level data. So why don't we get a bunch of experts together and do the best we can with the information we have right now? But that gets really hard because nowhere's going to have a group of MGH experts that are ready to sort of jump on a call. And so I'm trying to think about like, how do we think about scaling that? How do we get it to the fact that, I'm in Connecticut, we've got 2 mega academic health systems, but we got 15 probably or so community EDs that are not going to have the in-house consensus committee they can group together and do that. How are you seeing that happen? So how do we get this type of consensus process out farther?
Yeah, so there are two points that I think that you just made that I think are really important. One is that this is an intermediate step, but I think it's also worth recognizing that we always need intermediate steps. The technology are constantly advancing. We're never going to be at a point where all of the clinical trials have been done and we know all of the answers. So this is true of PE. This is true of any diagnosis, really, where we have some new technology that's come along, we're waiting for the data, and we need to figure out how that integrates into our current models of patient care. So yes, it's an intermediate step, but that intermediate step is always going to be necessary. The second question about how do we do this in places that maybe don't have MGH level resources? And there, I think some of the movement that we see in hospital systems and integration is going to be very helpful. The good thing about integration is that it provides access to some of the smaller community hospitals to some of the resources of the larger hospitals, and conversely provides some of the resources of the smaller hospitals, like, sometimes bed space, to the larger hospitals. So I think the way this is going to evolve is that PERT teams are going to be integrated into these sort of networks of care so that consultant teams can provide advice not only at the tertiary care center, but at the smaller hospitals that might be transferring patients in or might not have to because they already have access to this consultant team who's told them, no, I think the patient can stay with you as long as you provide good care and do anticoagulation. So I think that's really where this is going, is network level PERT teams. The challenge there is probably resources, right? Because we were lucky at MGH when we started, we had 4 fantastic vascular medicine fellows who took call for all of our PERT activations, and they were busy. And if we asked them to manage the other 7 hospitals in our network's calls, they'd be completely overwhelmed. So the hospitals, I think, need to figure out how to scale this system. Not that every hospital needs a PERT team, but there need to be the resources put into these teams so that it can serve the entire system.
Hey, shifting gears a little bit for our audience who might be wondering, how far and wide are PERT teams, do you think, spread across the United States and across different types of hospitals?
I think they are very widespread. I think that it's a little bit difficult to know because although there is the PERT consortium, I don't think that most hospitals who have PERT teams are necessarily listed as members. And so probably the vast majority of hospitals with PERT teams are uncounted. I know that there are PERT teams on at least 5 continents and maybe 6. I don't think there's one in Antarctica yet, although I'll look. So there are huge networks throughout Asia. I know China has hundreds of PERT teams. They exist throughout many hospitals in Europe and throughout a lot of hospitals in the United States. Now, one of the difficulties is defining what a PERT team is, because we never really defined that. And I think that's one of the reasons that it was successful when we first created it, is that we didn't tell hospitals that they needed to have interventional radiology and cardiology and cardiothoracic surgery on call all the time, because we knew not all hospitals have those resources. And so maybe you just have an interventional radiologist and a pulmonologist and a hematologist on your team, but maybe you just have a pulmonary critical care consult and you call that a PERT team. Well, I'm not sure that is a PERT team. I think at the very minimum, a PERT team has to be multidisciplinary, right? You have to have a couple different specialties, including emergency medicine, in my opinion, involved in your team so that you can get that diversity of opinion and mobilize different resources for a patient. So I don't know how many hospitals have what I would consider to be a PERT team, but I do believe it's quite widespread.
You mentioned earlier, I think in our previous podcast, the mortality associated with a high-risk PE. With this growing consortium of PERT-ready institutions and hospitals across the world, what's the data on impact on mortality?
There are a couple studies that have looked at this. One of them was at the University of Louisville, and the other one was out of the Cleveland Clinic. And there may be some additional studies that I haven't seen in the last few months, but both of those studies showed significant positive impacts with the development of a PERT team. These were essentially before and after type studies with all the limitations that come along with those. But they showed that when a PERT team was implemented, you had shortened time to therapeutic anticoagulation, decreased length of stay, decreased cost, and decreased mortality. So we don't have randomized or even cluster randomized trials of PERT teams, but the data certainly seem to indicate that we're having a positive benefit on patient outcomes. Another interesting thing, and this is more anecdotal, is that I feel like when places implement a PERT team, the process of multidisciplinary consultation tends to right size the intervention rate. At Mass General, before our PERT team, we were doing interventions at probably less than 3%, or for less than 3% of our patients. When we implemented the PERT team, about 10% of our intermediate and high-risk patients were now getting a catheter-directed procedure. Another 3 or so percent were getting interventional or IV thrombolysis rather, and another 2% or so were getting maybe a surgical intervention. So we wound up with an intervention rate that was around 14, 15%. At another hospital where prior to implementing their PERT team, every PE got a call to interventional radiology, their intervention rate was pushing 30%. And when they implemented the PERT team and there was now a multidisciplinary discussion, that rate actually fell to around the 14 to 15% rate that we were seeing for intermediate risk PEs. So I think that this process of multidisciplinary discussion has the potential to really right size the answer. Now, I can't tell you if that's exactly the right number, but I do think that, Arjun, as a quality researcher, you know well that when there's lots of variation, there's probably a gap in quality somewhere.
Exactly. Well, exactly. And actually, as you told that example, what it actually got me thinking about was, about 5-10 years ago in the quality world, there was a ton of research being done about these multidisciplinary tumor boards. And so in cancer care, we've taken multidisciplinary tumor boards and essentially made them standard. If you want to get your care at major cancer centers, there's going to be a multidisciplinary tumor board, and every patient with a new cancer diagnosis goes to it. And when I think back to the literature and the research on those, it almost sounds exactly like what you said about PE. Instead of it being time to anticoagulation, these tumor boards increase the time to initiation of treatment, whether that be surgical treatment, chemotherapy, or radiation. Also, same experience was found, which was that there was reduced sort of, call it, if you want, avoidable chemo or inappropriate chemo, or these sort of surgeries, more extensive surgeries that may have been not necessary at some institutions, while at other institutions you saw increases in some of those therapies, and it was getting exactly at that, reducing variation between sites, so that for a given patient with cancer, in this case a PE, whether you go to one ED or another ED, whether you get one person who's on call that day versus another person on call the next day, you don't get different treatment that's subject to that variability. And I think there's a lot of that opportunity in PE world because it's essentially been undefined for a while. And it sounds like that's what the PERT teams are really doing. That was interesting as you sort of spoke to some of those studies there. You live in this world of VTE research, and you're seeing a bunch of the science that's coming out. What do you think are some of the coolest things you've heard about at a meeting or seen published that, most sort of frontline emergency physicians, PAs, nurse practitioners may not be aware of, but we should be hearing about because it's going to be, hitting our practice in the next couple of years?
So in terms of PERT teams and interventions, it's worth knowing that there are at least 3 large randomized trials looking at catheter-directed interventions. I think those are going to be critically important. One of them is NIH funded, and that is a project that I've been peripherally involved with for almost a decade now, and I'm very excited to see the PE tract study moving forward and enrolling. So I think that's really important. I think the PE tract is particularly important because I think the data that we have thus far on the efficacy of catheter-based interventions, for example, has almost entirely been driven by industry funded studies. And we know that those are often very well done and good studies, but they are often done with an idea of selling a catheter. And I would like to see the NIH. I'm happy to see the NIH get behind this trial because I think it's going to be critically important. So we should keep an eye out for those. Some of the things that we talked about earlier in terms of scaling and virtual consultation, I think is something that we should be very well aware of. And then, to get a little bit personal, I am very much interested in some of the new technologies that I think are going to enable emergency physicians to make better decisions about the diagnosis of PE and the risk stratification of PE. One of the things that is obvious to us in the ED, but maybe not obvious to everyone else, is that we truly are the experts in taking an undifferentiated, acutely symptomatic or ill patient and deciding which tests to do and ultimately coming up with a diagnosis. That's our role in the medical system, probably more than, resuscitating a critically ill patient or securing an airway. We truly are diagnosticians. And I think the world of PE needs to advance in terms of diagnoses. And I think that some of the technology in terms of, for example, high throughput omics and machine learning, AI, are really going to improve our ability to do that. And I think if we are clever about how we use these technologies and we advance the science of diagnostics, then we are going to be critically important to the care of PE patients in the future.
That's a lot to think about, Chris. Thanks. I think it was a great summary. I'm really fascinated to learn about the history of the PERT and your thoughts on where it's going.
Yeah, and I think it's the point you make around diagnosis is really important. In our broader work as part of the EQUAL Collaborative, we have really focused on developing quality measures around diagnosis for PE. I think that the idea that you could maybe even change the name of the emergency department to the Acute Diagnostic Center in healthcare delivery is increasingly accepted. It doesn't sound as sexy as it needs to be, I think, for like making sure that we match all the best medical students into our specialty and that we keep that sort of part of the specialty live. But I do think it's real. If you have acute shortness of breath, chest pain, whatever it might be, you're going to find yourself in an emergency department setting. And that's where we have a lot of gaps to close around identifying PEs. And I think it's also concurrently where we have a lot of gaps to close, though, about these cascades of care. And so I really appreciate our conversation today. I think our listeners probably walk away from today recognizing that the idea of a PERT team is not something that lives in just the University Ivory Tower, that it doesn't mean that you have to have 20 people and all these different technologies and everything already set up. But that really what it is about trying to get the best of what we know today via a lot of this expert consensus to the bedside, while it sounds like there's a bunch of these big trials going on. And so we'll be sure to have you back in the future as those studies come out, talk to folks about it, help make sure that we're getting science to the bedside. And so thanks again for joining us. This was great.
I always love talking to you, and thanks for having me.
Thanks, Chris.